Hello everyone and welcome to today's session. I'm Deborah Garlick from Henpicked Menopause in the Workplace, Director of Menopause Friendly Australia and author of the book Menopause, The Change for the Better. And today's session is Polycystic Ovary Syndrome, or PCOS, and I'm delighted to welcome back the wonderful Dr. Clare Spencer from My Menopause Centre, rated outstanding for their support. And welcome, Clare. A little bit different for us today because usually these sessions are entirely about menopause, but of course we get asked a lot of questions about menstruation and menstrual health, and also how these conditions can also influence menopause. So welcome, Clare, and looking forward to today's session.
Thank you for having me, Deborah. Delightful to be here as ever.
Thank you, Clare. And the first question, I'm going to jump straight in and say, I always say PCOS. Some people call it PCOS. Some people say PCOS. Some people say the full polycystic ovary syndrome. But what actually is it?
Yeah, so it's a really great question because it's actually relatively poorly understood. So I call it PCOS, and this is a common condition. So it is really common in the population, and there's basically a hormonal imbalance. And this hormonal imbalance can then cause some or all of the following symptoms. So irregular periods or no periods, increased hair and acne, and it can also affect your fertility. And if you do an ultrasound scan on women with PCOS, then they may or may not have lots of little cysts in their ovaries. So the ovaries look bigger and they're filled with more little fluid-filled bubbles or cysts.
Wow. So actually, this might be where sometimes we get the crossover between menopause and ask the question, because hormonal imbalance is, of course, what we experience during perimenopause when things can fluctuate. And I can remember when I was experiencing perimenopause that one of my colleagues at the time said, do you think it could be PCOS? I have PCOS. And of course, you don't know, do you?
Well, you don't, but the hormonal imbalances are different in PCOS compared with the perimenopause. So with the perimenopause, we know that what happens is the really tight feedback mechanisms connecting your brain to your ovaries start to break down. So estrogen levels fluctuate wildly and then drop. What's happening with PCOS is that one of the key hormonal imbalances is actually with the hormone insulin. And so your body might be making the hormone insulin when, for example, we eat carbohydrates, because insulin has a really important role in our body. When we eat sugar or carbs, the insulin is secreted and it pushes the sugar or the carbohydrates into the cells and out of the bloodstream. But in PCOS, the body doesn't respond to the insulin in the same way. So you've got higher levels of glucose. So that's one thing. So increased risk of type 2 diabetes. And then the second thing is that actually your estrogen levels might be a bit higher, but the free androgens or free active testosterone levels might also be higher. And so that's why some of the symptoms include things like acne or extra hairs, where you really don't want extra hairs, like on your chin, chest, etc. So it is hormone imbalance, that's absolutely right, but different types of hormonal imbalance. And it can be really difficult if you've got PCOS and you're just having sporadic periods, or, you know, many women with PCOS don't ovulate, for example, where you pop a little egg every month. So if you've got PCOS and you're having really spaced out periods, you might not know from your periods if you're going into the perimenopause. So that's where that sort of crossover lies.
Okay, so it's good to understand the big difference there in terms of why it's happening. At what sort of age could somebody experience PCOS?
Yeah, so usually PCOS it shows itself from even when you've started your periods. So it's not always like this, but some women with PCOS have irregular periods. And so it may be that from the age of starting your periods, age 10 or 12, you always have spaced out periods or very few periods. But also, what can happen is some women have regular periods, and then there may be some changes in the body, or they may get, for example, gain weight, and then the periods become irregular. It's one of those funny types of condition where not everybody has all the symptoms. So PCOS is diagnosed using it. There's a criteria called the Rotterdam criteria, where the diagnosis is made if you've got 2 out of 3 of irregular periods or no periods, having clinical evidence of high testosterone or a blood test that shows high testosterone. So that's like the acne and the extra hairs, or polycystic appearance on the ultrasound. So if you can imagine, if you only need 2 out of those 3 criteria to be diagnosed, and there's a whole spectrum from people who have very, very mild symptoms, may have regular periods, just the odd extra acne spot, etc., to women who, you know, might only have 1 or 2 periods a year, who may not be ovulating, who may be finding it difficult to get pregnant, for example. So there's a really big spectrum of symptoms.
That's really fascinating. So when you went, you know, that the Rotterdam, did you call it?
Rotterdam criteria is one of the criteria. Yes,
it's one of the criteria, but actually you could be living with this condition for a very long time and just think you've got irregular periods, or you know, what did you say, irregular periods, the clinical acne, excessive hair, or hair growth where you're not expecting it. So but some people might not actually associate that that's actually what they're experiencing. Would you say, I mean, and I know I can imagine there's not an awful lot of data on this, how many of us could be experiencing this?
Yeah, no, it really is quite common, and so it can affect the research varies, but between 2 and 26 in 100 women. So it could be as much as 1 in 4 women, depending on the studies that you read, obviously. But, you know, it really can be common. And obviously, you know, there will be a small percentage of women who have it, who don't have a diagnosis, who don't realize, just because, you know, they've always had, say, 35-day or 40-day cycles and they've not gone to the doctor, etc.
Okay, so one of the things, because you've mentioned some of the symptoms there, and some people might be on the extreme of just thinking, oh, I just don't have periods every, you know, I've got a long cycle, or something like that. But so, and you've explained around the diagnosis. What are the risks for PCOS? Because that actually drives the importance of having a diagnosis, doesn't it?
Yes, no, absolutely. And because mainly related to the effects of insulin resistance in the body, actually the long-term health consequences can be, it's really important to know about them because they can have lasting effects. So for example, there's an increased risk of type 2 diabetes. We know that there's an increased risk of heart disease from having polycystic ovarian syndrome. Some women are more likely to get higher blood pressure, but that's more related to the insulin resistance, and often that goes hand in hand with difficulty losing weight, and so obesity. There's increased risk of sleep apnea, where when you're asleep, you may pause your breathing and then wake up suddenly, and can mean that you wake up in the morning feeling you've had a really terrible night's sleep, or headaches, for example. And actually, some women experience anxiety and depression, which is important to know about as well because of this condition and the effects. Some women, but not everybody, important to stress, may struggle to become pregnant. And if this is you, please don't worry, because there are lots of ways that you can help support getting pregnant, particularly through fertility clinics, with what we call ovulation induction, etc. But so you can see the effects are quite far and wide reaching, and it's important that we talk about them because there's lots that you can do to mitigate those risks. Yeah. Oh, Deborah, you're on mute.
And that's exactly what I'm going to ask you now. What if somebody is diagnosed with PCOS, what can they do to manage the symptoms and their overall long-term health?
Yes, brilliant question, because heart disease is the leading cause of death for women worldwide. And so if we think about the risks that I've just spoken about, it's making sure that you can do everything to reduce and manage your other risk factors for heart disease. So you can guess what I'm going to say. So don't smoke, don't drink excessively. It's really important you look at your diet and exercise and manage your weight, which can be a struggle for women with PCOS. You know, it can be much harder work to shave that weight down. It's keeping an eye on your cholesterol and making sure that that's within the right range for you. It's keeping an eye on your blood pressure, making sure that your blood pressure stays nice and low, and looking at your glucose tolerance. So there are tests that you can do to look at how your body is handling sugar, glucose, and check that you are not at risk of developing diabetes through various blood tests. And the other thing that I didn't mention, specifically with PCOS, it's really important that you have about 4 bleeds a year. So if you have PCOS and you're not having periods, actually, unlike the perimenopause, it can be because the womb lining, if you don't shed the womb lining, if you're not having a period, the womb lining can build up to be really thick. And that can then increase the risk of abnormal cells and even cancer of the womb lining. So that's quite straightforward to manage. If that's happening to you, your doctor can give you short courses of hormones to induce a bleed. You can say go on the pill. You could have a Mirena coil fit to prevent that happening. So risks of heart disease, risks of thickening of the womb lining, but there is lots that we can do to manage those risks.
Well, oh, wow. You know, when you just said that, I was thinking, I wonder how many people have not had that many periods, and particularly if your cycle is very long and you just don't think about, you know, if it's something that you're used to, because that you think that is your normal.
Yeah.
And you know, you're not having periods as often as you think, you know, as 4 times a year, that's, you know, you wouldn't have to have that long a cycle, would you? Just a couple of months, 2-3 months.
Yeah, as long as you're having a bleed every 3 months, as long as you get a quarterly bleed in, you know, then that does mitigate that risk. And again, often women don't bleed in the perimenopause for really long periods of time. But that's different. Usually that's because of a low estrogen. So the womb lining doesn't usually build up to be very thick. But if you have PCOS, if you're during your reproductive years, it is important that you induce a bleed, which, as I say, is relatively straightforward to do with just occasional short courses of a hormone called progestogen. So just speak to your doctor if you're worried about that.
Yeah, keep your eye out on what's going on for you. And I'm just following on from that in terms of the crossover between those experiencing PCOS and perimenopause. And, you know, is there much research to say how they interact with each other?
Yeah, so, well, the answer is no, there's not much research, but we know that although various groups internationally have tried to sort of set criteria, like, for example, the STRAW group, STRAW, of reproductive stages in life to set sort of, you know, late reproductive years, for example, early perimenopause, and then et cetera, to the menopause. But you can't apply the normal criteria to women who have PCOS, because you may only have been having 4 or 5 periods a year anyway during your life. So you can't look at changes in hormones in the same way. But you will still go through the perimenopause, you know, you will still have the symptoms of erratic estrogen changes, you'll still have the symptoms of estrogen loss, and your periods will eventually stop. You'll go through the menopause, We don't really know if there's any change in age of the menopause as yet, because again, there's such a lack of research, but usually then the symptoms of PCOS then resolve as time goes on in the post-menopause. But obviously you've still got that underlying slightly higher risk of heart disease and type 2 diabetes. So it's just really important that you really take care of your health and your body. And as I said, manage those risk factors and try and be as healthy as you can be, and talk to your doctor about doing the checks for blood pressure and cholesterol.
Wonderful, Claire. Thank you. Can I just take you back one step? Because you mentioned fertility. And of course, menstruation, menstrual health is a long time. If somebody is experiencing infertility, that may be a trigger to go and talk to their doctor. But you mentioned that there's things that you can do if you're experiencing infertility. And to be fair, you know, it can be a really devastating time for individuals and very stressful if you're trying to get pregnant. What sort of treatments can be used if somebody is struggling to get pregnant because of PCOS?
Yeah, so really specifically, so keeping your body mass index within normal limits can have a really significant impact. So it can make the impact of weight and weight loss can make the difference between ovulating and not ovulating. So if, for example, your body mass index is over 30, the doctor will talk to you about ways of losing weight, because that can be really helpful. And then if you're not ovulating because of PCOS, then the fertility specialist will talk to you about ovulation induction, if that's suitable for you. But this is then becoming a bit of a specialist area. And I think the take-home message is there are plenty of things that can be offered. You can do the best that you can with weight loss, leading the healthiest lifestyle that you can. And then it's asking your GP for a referral sooner rather than later to a fertility specialist. So if you have PCOS and you're worried about becoming pregnant, then obviously please speak to your GP. You would be somebody who you wouldn't want to leave for a long time waiting. It's best to get that specialist advice earlier.
Thank you very much, Dr. Clare. And I'm going to invite my colleague, Sally, because I can see there's lots of questions in the chat. Hi, Sally.
Hi. Yeah, and just again, as always on these sessions, thank you everyone for sharing. You know, people have shared some really tough experiences they've had, and sharing those stories again helps to normalize this for everybody. And the reassurance and that shared experience is really appreciated in the chat and on the Q&A. So thank you very much. So we've got a few themes coming out. So one of the questions was, is PCOS, or can PCOS be hereditary?
Yes, brilliant question. And although we don't know the cause for PCOS, we do know that it can run in families. So if you've got a granny, an aunt, sister, etc. with PCOS, it does make it a bit more likely that you might have it as well. So yes, no, it can run in families. Yeah.
And obviously we talked about weight and how that can support looking after the body. Someone's asked us, how does PCOS impact weight? So does it cause weight gain in terms of what's going on in the body? And is there something that people need to consider outside of the normal being healthy that might support someone to lose that weight if they needed to?
Yeah, so with insulin resistance, which we know also occurs in the menopause transition with the loss of estrogen. So with insulin resistance, you're more likely to put weight on around the middle, and that central obesity then makes insulin resistance worse. And so it's really talking with somebody who understands about that. So a dietitian, for example, who it's all about it's not cutting out carbs at all, but, you know, looking at a diet with more slow release carbohydrate than fast release carbohydrate. So that's things like the difference between a slower release carbohydrate from a sweet potato versus faster release from just from a normal King Edward potato, for example. And it can be more challenging to lose weight because of the insulin resistance. It's absolutely possible. It's just making changes that you can keep going for the rest of your life, rather than dietary quick fix fad diet type changes. But if you're concerned about it, then actually talking to a dietitian or somebody who's got an interest in this. The practice nurses are often quite good in GP because they're used to advising people with type 2 diabetes about their weight. It's that sort of advice that you need.
Fantastic, thank you. And someone's just talked about they were diagnosed with PCOS in their early 30s. They had an ultrasound which showed cysts on her ovaries, had another ultrasound about 2 years later and was told there were none. Can this happen where cysts disappear?
Yes, no, I have seen that. And also, but just because you've got cysts on your ovary doesn't mean that you have PCOS. Interestingly, you can have polycystic looking ovaries, but have none of the other changes that go with PCOS, which I know is a bit confusing. And yes, they can resolve also. Yeah.
Okay. And there were quite a few questions around having the periods 4 times a year, where people have been put on the contraceptive, whether pill or implant. So they're either having light spotting or they're not having periods. Is that okay when you've got PCOS, or what? Because obviously periods. So just a little bit around that would be really helpful.
No. So PCOS is a bit like the wild west of hormones if you don't take any hormones. And I think if you think about like being on the combined pill, being on the mini pill, being on the implant or the injection, having a Mirena fit, all work to prevent that thickening of the womb lining. So I know it's a bit confusing and it contradicts what I've just said. But if you are taking hormones and not bleeding, that's okay, because the hormones will be managing the womb lining. So if you have spotting, though, it is worth just maybe, the problem is it is quite common to get spotting with the implant and the mini pill, for example, and all of them can cause spotting. So if you are having spotting, it's probably worth just getting it checked out. But the likelihood is that form of contraception, that hormonal treatment, is keeping your womb lining thin. And so it's not a worry. Whereas if you weren't taking any hormones and you have PCOS and you only have 2 or 3 bleeds a year, then you would want to do something about that.
Yeah, okay, that's really helpful. And I think there's and it's similar when it comes to when we talk about menopause, the frustration of focusing on eating healthy. But if someone is living a healthy lifestyle, they've got a good weight, but they're really struggling with the impact of this, I think there feels to be a bit of a frustration in terms of, well, what can I do? And not feeling they're getting anywhere with their doctor. And just kind of any advice you would give when someone's maybe feeling that really frustrated, I'm doing everything I can do, but I feel like I'm really struggling with this.
Yeah, so if you really, really are not losing weight and you're exercising and you're having a really, somebody's looked over your diet and you're being completely honest with yourself about what's going in and what's going out, then sometimes the endocrinologist can be helpful. And that might be an endocrinologist, or it might be a gynecological endocrinologist, because sometimes there are medicines or medication, for example, metformin, that is sometimes given. The evidence around using metformin, which is a diabetic drug for PCOS, is not brilliant. But having a chat about your symptoms, your circumstances in relation to that with a specialist. So it's not something that your GP is likely to be able to advise on. You will need to speak to a specialist, but do speak to a specialist. But keeping a food diary is often really useful, because sometimes, just to make sure that you really are having as tighter intake as you think you are. Also, I'm not saying that you're not being honest with yourself, but just make sure you're optimizing diet, optimize exercise, and get specialist input.
Yeah, and I think someone raised a really good point around PCOS not just being a fertility problem, because obviously it can have an impact, and a devastating impact for some, but actually outside of that, it can have a really big impact on how someone's feeling.
Absolutely, we know that. And as I've said already, if you have, if you're carrying the extra weight around and you really think that you're doing everything you can, You have doctors saying, just manage your weight and exercise. It's so frustrating, especially if you know that, you know, you've been advised often to lose weight for fertility treatment. So often fertility clinics won't give treatment if your body mass index is over a certain point. It's really frustrating, and getting some help early, you know, getting therapy, talking therapies, etc., is so important, because we know that there's increased risk of anxiety and depression for women who are struggling with PCOS. Absolutely. It's really hard.
Yeah, and I think it's really great sharing, and so really appreciate it from people. Someone asked, what's the best thing to do to help a teenager manage PCOS? So not much help has been given by GPs. It's taken us 4 years to get a diagnosis. When bleeds happen, they're extremely heavy and can be a cause for embarrassment. Is there anything you'd recommend that could help?
Yeah, so the combined pill, not for contraception, but to help just manage the hormones, and that hormonal balance can be really helpful. It can regulate periods, can help some of the other symptoms like acne, like the medical term for extra hair is hirsutism, HIRSUTISM. So hirsutism can be helped by the combined pill as well. So don't be afraid of the combined pill, because there are lots of different types with different doses and different types of hormones in. So I would find a GP who's used to prescribing the pill, and it may be that you need a referral to a gynecologist with an interest in adolescent gynecology if your GP can't help you.
And someone's asked a kind of a follow-on from that. If their daughter who's 15 has been put on the pill to be able to manage PCOS, will she need to stay on that?
So that's a really good question. Whenever you're on the pill, it will help manage the symptoms. And when you stop the pill, symptoms can come back. But obviously, if down the line she wants to start a family, then it would need stopping. So sometimes there's a bit of starting and stopping that goes on, but it's just really individual how different people react. Yeah.
Absolutely. There's a question that someone's asked as well around, and this is probably more for Deborah and I to answer, around what can employers do to support. And I think it's very much, when we think about how we support menopause at work, it's understanding what would make a difference to that individual person, because everyone's journey through this is going to be very different, in the same way as everyone's journey through menopause is different. So the impact it may be having will be different for each person. And it's coming back to all of those things we think about from a menopause perspective, in terms of having a good supportive conversation, understanding the impact and what's getting in the way for somebody at work of them feeling comfortable in managing the way this is showing up for them, and what would be supportive, what would be helpful. And, you know, often, you know, we're hearing from people things like the flexibility, the understanding, those are the things that make a big difference. So a really great question coming through. We've had a few questions around endometriosis. To let you know, we've got a session specifically on endometriosis on the 27th of November, which you can register for at henpicked.net. And also the recording will be available there and sent out. But I will pass back to Deborah.
Thank you very much, Sally, and thank you to everyone for all of your questions. It's quite clear that this can be a very distressing condition, actually, whether it's you experiencing it yourself, or we've had a few questions come in around my daughter is experiencing this. And thank you very much, Dr. Clare, for giving us the answers to these. We will send out this recording, and we'll write up the notes. And also there was some signposting there to other resources that people have found helpful in their journey. So we look forward to seeing you again. And I'll just end on the thank you very much, Sally and Dr. Clare. Wonderful as always.
Thank you.
Thank you.